Welcome to this webinar, Rethinking Secondary Care Mental Health, Community and Mental Health Care Services, brought to you by SBK Healthcare and presented by Nick Hardwood and Steve Skinner of the Adult Mental Health Service Community Division at Lincolnshire Partnerships NHS Foundation Trust. To view more of our content, please do visit our website www.sbk-healthcare.co.uk, where you'll see our online courses, face-to-face conferences and workshops. Thank you. I'd love to introduce today's webinar speakers. We've got Steve Skinner, the Service Development Lead, and Nick Harwood, the Associate Director of Operations at Adult Mental Health Community Division, Lincolnshire Partnership NHS Foundation Trust. They should be appearing on screen. There we are. Hi, Steve. Hi, Nick. Thank you so much. I will leave you guys to it and I'll see you at the end. Thanks, everyone.
Thanks, Vanessa, and good afternoon, everybody. As Vanessa has just said, I'm Nick Harwood, the Associate Director of Operations for the Adult Community Division in LPFT, that's in Lincolnshire, and I'm joined by Steve today.
Afternoon, everybody. I'm Steve Skinner. I'm the Service Development Lead in the Adult Community Division, working alongside Nick around a lot of the work that we're going to share today.
So yes, we've just introduced ourselves. In terms of today's session, I guess a broad title around rethinking secondary care mental health in community mental health services. So given we've only got kind of 40 minutes today, or 35, probably a bit of a whistle-stop tour, but we wanted to focus on some areas in particular. And we could and would love to talk all day about community mental health transformation and all the exciting opportunities that could bring and will bring for the people that we serve. Yeah, so just in terms of the things that we're going to talk about today, just a little bit about the national picture and the expectations that are placed upon us in terms of how we're going to transform and develop our services going forward. A little bit about our approach to that and some of the things we've been working on, and a bit more of a focus really on some of the new roles that we've introduced as part of this programme of work. And Steve's going to talk a little bit about digital and how we're thinking about linking the digital pathways. I guess many of us are well versed in the Talking Therapies service and how we've used digital in that, but how do we transfer some of that learning across to other areas of mental health, particularly secondary mental health. And we want to talk a little bit about those connections between the community mental health transformation and the Talking Therapies for anxiety and depression services. And I can see a number of colleagues from and I'm finding it really hard not to say IAPT, like many of us, I'm sure, but those talking therapy services and that connection. So just in terms of the national picture, I guess there's two things that are going to guide us through this. One is all the information around the community mental health transformation. There's the reams of information from NHS England on Future's website. And there are also summaries, I guess, or different ways of viewing the information. The King's Fund have got quite a lot of stuff on this. Royal College of Psychiatrists and Rethink have also done their kind of interpretation. So there's a number of documents to refer to. And I guess quite handily for this presentation that in July was the guidance that came out in regards to those connections between community mental health in secondary care and the Talking Therapies for anxiety and depression services, and how we ought to be thinking about that. So a bit of a nod to that later on. So probably a slide that certainly people working in the community mental health transformation space will be very aware of. I don't intend to go through all of the elements of this, more, I guess, just to have a view of the enormity, really, of the work. And I guess what's the most exciting part of it is the investment and the resource and the time that's gone to thinking about community mental health, those teams that have been core to our provision in mental health services. As many services have come and gone, specialist elements, they've remained, and now is the time, and has been the time in these last couple of years, to invest in those services, ensure that they are fit for the future. But I guess some of the main headings at the top are the bits that are, I guess, worthy of note. So developing models. There's significant talk in there about PCNs, localities, all those kind of bits and pieces, how we work closer to where people are. Care provision, how are we going to deliver that? Things around increasing and improving the access to psychological therapies. Again, something we've been very to in our Talking Therapies teams. How do we transfer that learning? Workforce, quite a significant challenge. Lots of investment into mental health, which is amazing. But I'm sure most of us, many of us are experiencing the difficulty and then recruiting to a lot of the posts that we've put into, increasing our workforce. And how can we think about that a little bit differently? Data and outcomes, again, an area very, very familiar to Talking Therapy teams in terms of collecting lots of meaningful data to inform service expansion and delivery going forward. And outcome measures, something that's probably slipped behind or is now the time to invest more effort and kind of experience from across other services and how we really monitor outcome data. And then 3 dedicated focused areas in which the transformation is expected to see either expansion of these services or develop them from new for areas who didn't have them. So services for people with personality difficulties, community rehabilitation, and that kind of expansion as we've seen that prevalence of eating disorders go up, certainly off the back of the pandemic. So an overview of what the community mental health transformation is attempting to achieve. And every single one of those green boxes has about 20 pages that sits underneath them in terms of guidance. So there's a lot to read if you fancy having a look through. So in terms of some key areas, I've touched upon them a little bit, but in Lincolnshire, we were one of 12 early implementers. So I guess we had a little bit of a head start on other areas. If I was to sit here today, we've cracked it all, I would be lying, because there's an awful lot to do and a number of challenges. But just being mindful really that the focus of the programme is around severe mental illness, but also around closing gaps. We know as services have developed, when resources are stretched, services can become a little siloed and have quite rigid referral criteria, meaning that we often have people who fall through the gaps in our services. A real focus on population health, understanding our localities. I think gone are the days where we are given a model from centrally and asked to deliver that to the whole country and every single area, when in fact what we need to do is tailor our services to our population's needs and understanding those needs. So understanding what our population, what our localities actually require and what is there, what's going on in those areas, what is the different prevalences of illnesses, etc. Obviously, in the middle of this, primary care networks came in. And in terms of our alignment to them, a really important piece of work, if we're to realise that kind of flow and fluidity across pathways so that people aren't always being seen just in a mental health provider service. I'm sure people on the webinar can resonate around the high demand in those services and the lack of capacity, and sometimes the difficulty in transitioning people out of services back into their communities and into primary care. Again, some of those key principles, they're easy to say, hard to do, and quite a challenge. I talked a little bit about that. Rigidity around some of our referral criteria sometimes, which is inevitable when you lack in resource. But the principles around no wrong front door, wherever somebody puts their hand up for mental health care, we should be able to respond to that. If it's not always the provider that needs to provide the intervention, we're doing some warm, trauma-informed handovers and signposting. And we don't just say, you don't meet our criteria, because it's very brave to put your hand up and say, I think I've got a mental health problem. No cliff edges. What a lot of people have said about mental health services in England is that when you get in, the service is generally very good, but it took a bit of time to get in. It wasn't easy to navigate. And I guess that's why when people are in, they're reluctant to let go, or we're reluctant to let go too, because of those potential cliff edges. We've got to fill them gaps. Ensure that we've got seamless pathways across our services, so that it doesn't feel like, from my point of view, people are being referred on to lots of different services all the time. It's just part of a pathway in which people can access their care. Our engagement with primary care is really important. We've certainly done a lot of work. We've embedded primary care champions. So an interested person, I'm not going to say it's all GPs because it's not, but it is a majority of GPs that have got a special interest in mental health and are helping us in those localities to ensure that we've got those seamless pathways from primary care through to secondary care. And then, of course, a really, really important part of the programme is the engagement of our community and our voluntary community and social enterprise sector. Certainly in Lincolnshire, we've put in a significant amount of money into growing that sector, ensuring it's sustainable for the future and it's meeting the needs of our population. and that they're kind of connected. We're joining them together so that I guess their voice is louder together. A lot of these organisations are 2 or 3 people doing really good stuff, but haven't felt very connected to the wider system. New models and specialist services I talked about in that first slide, so ongoing development of those. New roles, thinking about things differently. That traditional registered workforce isn't necessarily there in the volume that we need it to be. So how can we complement the roles that we've got in existence by bringing in some of the new roles? Increasing access to psychological therapies, ensuring that the approaches that we take within our services are psychologically minded, that we move in conjunction, but certainly where medication is not necessarily required, we have the alternatives to that and those good pathways of care for psychological intervention. Supported by national programme of training from what was Health Education England, now part of NHS England, to ensure that we are upskilling our workforce to be able to work in that psychological way. And outcome measures, it's, I guess, a bit of a surprise, I imagine, that outcome measures have not been a routine part of the business within secondary mental health care. They are in some services and they are in pockets and with some disciplines. But this is now about how do we match and mirror what we know was really effective in our Talking Therapies teams into our secondary care mental health teams, so that people, our patients, understand the things that are happening to them, their improvements or areas that they need to work on. And as therapists and clinicians, we also know the progress that people are making. So just in terms of our approach to some of this, integration being a really important part of the pathway, having clear pathways that are free from muddle, I guess, and that are easy to navigate by the people who use our services. Some new roles that we're going to talk about, and some of those digital elements that I mentioned earlier. Just a kind of idea, just to, I guess, to visually demonstrate our thinking around these fluid models of care. A nice old inverted triangle that everyone likes, but kind of at the top there, you can see our strength-based community asset approach. So using people's communities, the things available to them, thinking about early intervention and prevention, really important elements. So that kind of sitting across everything that we do, really. And then we've developed locality-based teams that sort of are plugging the gap between primary care and secondary care and people's communities. So a range of disciplines in there. We do have clinicians in there, but also some other roles that Steve's going to briefly mention when we move on to his section. But things like community connectors. How do we ensure that there's somebody available in each locality to bring together the community offering and make sure that that's communicated to the wider services? And then we move up to our specialist services. We really see the future as a mental health provider, providing those really specialist interventions and services for the most complex, and ensuring people can move between the stages. It's not a static model. This is a continuum. People can come in and out of the services. And I guess what we need to get to, not say we've cracked this, is that when people need the specialist elements and the elements that we want to provide in the future, that they are available in a timely way. There aren't any long waiting lists that, we missed the opportunity, if you like. We missed that moment in time. So that's probably enough from me setting a bit of the scene, and I'm just going to ask Steve now to take over and talk to you about these other elements.
Good afternoon, everybody. I'm just going to start out by just discussing some of the new roles, really, following on from what Nick's been talking about. I guess it feels a little bit disingenuous to me when we talk about new roles in general, because we actually have a fantastic workforce already in secondary care who provide a massive value to the people that we treat. And a lot of the work in developing new roles has actually been around freeing up the time for some of these existing members of staff to engage in their own developments around some of the service moves that we want to make and strengthening some of the areas we want to strengthen in the new world order. So in relation to these roles, so we've introduced nursing associate roles, which for many of you will now is part of the nursing fraternity, who have developed a specific degree level course in terms of moving people from non-registered roles towards a career in nursing, should they wish, but also having a defined role registered with the NMC within itself. I'm going to talk a little bit in more detail about the PIF role and the mental health and wellbeing practitioner role, so I won't cover those in great degree. As Nick said, the community connectors are really important for us, being based in community services, linking our PCN offer and connecting up a lot of the services and wellbeing activities in and around practices, and also linking into some of the other developments we've had. So, for example, the nightlight cafes, they often coordinate the nightlight cafes, which have added a safe place for people in an evening to go to as part of their wider care and support plan. We've significantly increased the number of peer support workers across the organisation who do valuable work on a day-to-day basis, but also enabled some of our peer support workers to take on more senior roles in developing people and supporting people through, with their own lived experience into helping others. And the social prescribing link workers who, again, as with the community connectors, provide a really essential link between a lot of the community services. Next slide, please, Nick. So our starting point for the introduction of the PIF role and the mental health and wellbeing practitioner role, and a lot of the others, was the rapid need for us to upscale our services to meet the demands of the new primary care model. And when we looked at it, there was really quite a lack of career progression for people coming through secondary care careers, not just from non-registered roles, but in particular, this was an area we wanted to focus on. We'd found from recruitment that a number of the practitioner posts weren't necessarily getting filled with people with both the academic requirements and the clinical experience. It was either an either or. And across the workforce, we noticed that we had a number of part-time staff, but only full-time study options were being put forward to us as a way in which we could engage the workforce and upskill. So we also thought about the fact that we have a number of experienced community support staff in roles who could potentially be leapfrogged by people coming in band 5 roles when they're in existing band 4 positions. So we didn't want to lose that valuable experience within our community teams, but we wanted to make people part of it. Next slide, Nick, please. So we also thought about, how do we enhance the role of lived experience across the workforce? We increased the peer support offer, but that's just one element of bringing in lived experience into the workforce. So we wanted to really think about how we could make the service provision a lot more reflective of the populations we serve, and really investing in local services and local people in the same context as what we want to look at the population health in relation to delivering services. And also, having come from a very structured background in terms of talking therapies, we noticed pretty quickly that a number of practitioners weren't necessarily getting the support and guidance which was essential in keeping both the patients on track, but also keeping therapists safe. So we wanted to do some work around our supervision structures and also making sure that people had the appropriate training alongside the expectations of what they were going to deliver. And we had an existing development programme for our band 2 and band 3 workforce, which really focused in on retention and had been quite successful in retaining people, but hadn't necessarily offered anything for our existing band 4 workforce. Next slide, Nick, please. So what we decided to do was to stand on our heads for a little bit and just try and forget about the problem. No, what we tried to do is to think about it in an alternative way. So to try and turn the problem upside down. So instead of focusing in on the workforce that wasn't available, let's focus in on the people that we do have within the services, and also think about the skills and requirements that we need for the model going forward. Next slide, Nick, please. So we introduced a brand new role, and this role really focused in on our existing Band 4s to start with. And we alongside it developed a vocational training program within the trust. And the purpose of that was really to make sure that we focused in on the skills which we thought were essential in moving people towards a career in psychological therapies, existing the psychological mindedness of our existing workforce, and also giving us the opportunity to let our practitioners, our existing practitioners, engage within some of the structured training courses that Health Education England were offering. A number of our practitioners didn't necessarily feel confident in engaging or embarking on a period of study, and hadn't really had the structure around them which those sorts of courses demand. So subsequently, due to the success that we've had with these roles, we've been able to actively recruit to these posts with people that maybe don't have existing experience but have the relevant qualifications to move into these roles, and that space has been created by a number of our original cohorts for the PIF training moving on to do their mental health and wellbeing practitioner training. So we've been able to step people up quite nicely. So next slide, Nick, please. So the training that we've provided has focused on a number of elements. So core therapy skills, so making sure that people feel confident in their communication skills of delivering therapy. Revisiting some of the theory around cognitive and behavioural practice, so people could be very confident in the rationales as to why they were delivering the interventions they were delivering, and feeling confident they understood why, rather than just doing it because they've always done it in that way. We introduced a number of the wellbeing interventions similar to the mental health and wellbeing practitioner program. We've introduced CBT programs specifically focused in on secondary care provision, which I'll talk about a little bit more later. We also used it as part of our as a starting point for our change, moving away from the care program approach to a new approach of care and support planning, using a particular model which focuses in on changing the way we go around care planning. So introducing what matters to people and really focusing in on a wider aspect of who's on that person's team. So not just thinking about the interventions that are readily available, but thinking about all the different aspects of the wider community model and community resources that could be involved. We added in the psychosis and bipolar training, which is a particular training which is available from Health Education England, which fitted the needs quite nicely, and really supported people in developing their reflexive practice and use of clinical supervision in meeting the needs of a wide variety of people within their particular areas. And it resulted in, at the end of the training program, which initially started with a 2-week block, followed by 16 weeks, of 1 day a week with supervision and teaching attached. They developed quite a nice little portfolio, which they could then take to their interviews, should they wish to go on to be mental health and wellbeing practitioners or PWPs following applications. And some people have decided to, some people have decided to remain within the PIF role. They quite like it, but it's been very well received by the staff that have used it, and also has enabled us to bring a number of new staff in to develop for the future. Next slide, Nick, please. So one of the other roles that we've invested in quite heavily is the mental health and wellbeing practitioner role, which very similar to the educational practitioner roles within CAMS and the PWP roles in Talking Therapies. The mental health and wellbeing practitioner role has been specifically developed to focus on people with a severe and enduring mental health difficulties, providing a number of evidence-based interventions for the cohort. So next slide, Nick, please. So you'll see that we've got behavioural activation and exposure, which very familiar to us within the talking therapies world, but with a specific focus on the use of goals-based outcomes. So a slightly different application, which has been shown to be more effective with an SMI population. A number of different interventions which talking therapies staff will be quite familiar with the addition there of working with guided self-help for bulimia and binge eating disorder, linked to the development in community teams of eating disorder provision. Building confidence, which is quite allied to the work in behavioural activation, but very, very well received in terms of a number of people looking to develop their confidence, having experienced, quite severe and enduring mental health symptoms for quite a while. Next slide, Nick, please. So we've also, as I referred to earlier, implemented some digital work within the secondary care framework, and there's a number of bits of learning from it, really. And I think one of the most important things where we're thinking about the link between talking therapies and secondary care is that we don't replicate what talking therapy services offer in secondary care. Rather, we think about the actual needs in the secondary care provision. That's really important for me because there's an argument there to keep people within talking therapy services for a lot longer, if not. And what we've tended to find over the years is that the needs are quite wide and varied, and not necessarily have been addressed in that arena because the person requires a full multidisciplinary approach. Blended delivery is also really important in secondary care. So we've in the work that we've done around implementing CCBT, we've made sure that there's an increased element on face-to-face delivery. So we wanted to make sure that people were being seen, mainly due to the risk factors, which I know have put a lot of people off using digital products within secondary care settings. But digital's really proven to be really effective for us in the early stages of its implementation. We found it, practitioners have found it very helpful. Patients have reported back to us that they've found it refreshing in that they can revisit the information as much as they like. It's been very tailored in terms of the needs of the population. So the particular programs we've used have looked at things like trauma-informed care, individualized care and support planning, grounding strategies, and have really linked into the wider work that has been done face to face. But there's an ongoing need, really, I think, around digital to think about how we can make the best use of digital within secondary care platforms. So one of the, there are three particular areas of focus for me within that. So the first one being how do people access the service and move through that onboarding process? Are there things that we can do digitally better in secondary care services? Obviously, there's been a lot of investment within talking therapy services around that, but it seems to have not necessarily been incorporated into those secondary care pathways. Secondly, as we talked about a little bit there around the use of digital products in the delivery of care, I think is a really important element of development. And we need to really grow that evidence base to support the development of effective secondary care focused programs. And thirdly, relapse prevention planning. So making sure that people have the gains that they've made throughout treatment and can revisit the information on a regular basis to maintain the gains which they've made. And as with the talking therapies world, I think there's an element of some wider system regulation being quite helpful in terms of making sure that we all work together as services across the country to both develop that evidence base, but also to work on a national infrastructure digitally to support the ongoing delivery of services. Over to you, Nick, I think.
Thank you, Steve. So just in terms of the final bit that we're thinking about, gone too far, was just in terms of that the link between our talking therapies for anxiety and depression and our community mental health teams and that transformation element. And like I said, helpfully, we've got a guide come through not all that long ago from NHS England with 4 key principles really to think about. The first one being about how to improve appropriate referrals to community mental health teams and to NHS Talking Therapies. I guess part of that is I don't know if other systems or the providers encounter this, that kind of bouncing backwards and forwards of people who we don't quite think meets our criteria. So being quite clear about that, but also being clear about what service are we providing for people who might fall into that gap. And again, I guess this follows on from that. That principle 2 is about that ability for people to move between services. I think in the past there's been a risk of seeing them as very separate. I guess the new guidance and some of the new information within the Talking Therapies for Anxiety and Depression handbook manual. I mean, I guess it's not necessarily talking about blurring the edges, because we need to provide the best evidence-based approaches to that, but also making sure our whole population benefits. Principle 3, I guess we've talked about earlier, which is how do we increase the provision of evidence-based psychological therapies for severe mental health problems and that outcome monitoring as part of the transformation. But I guess that's sometimes where we encounter that people being, well monitored and the outcomes being really clear from our talking therapist teams, and that being less clear in our community mental health team, where there's a range of professionals kind of intervening. And then that 4th principle is about avoiding duplication across our provision. And I guess as the community mental health team element becomes more mature in its provision of psychological therapies, that we're not duplicating work, that we, as I said earlier, those clear pathways between services and within services, so that people know what it is they need to access where and when. And we make that navigation element straightforward for people. Again, that's something that our service users report is really difficult, and actually some of the professionals that refer into our services too. So just some considerations really, or sort of some of the things it made me think about when reviewing that documentation. So the first thing I did was to kind of benchmark against the guidance. I've given those 4 principles, but the document itself goes into a lot more detail about how to do that. So certainly have a look. And I suppose maybe easy for me and others that have their talking therapists departments within the provider. So in terms of my division, I have both the community mental health transformation and our talking therapists for anxiety and depression. So I guess quite easy for me to ensure that we're looking at that in a seamless way. I guess a little more challenging for those providers that are, outside of the NHS, etc., and how you link into your providers to ensure that. So maybe getting together to do that benchmarking might be a really important exercise. And I guess off the back of that, being honest about the gaps that you have got within your services and acknowledging where they are and how you're going to fill those. One for us, quite a number of years ago, we fully embedded our psychology provision within our community mental health teams, and therefore followed the same criteria of severe and enduring, and etc. And it's left a bit of a gap for people with quite complex trauma, complex PTSD, where I guess you're not quite thinking about this as a severe mental illness. There's reasonable functioning, but there's high levels of distress. And I guess some of our staff in talking therapies would say they're beyond single incident or single theme into more complex PTSD, but not quite meeting the criteria for our secondary mental health services, therefore a gap. So we're certainly thinking about how we plug that gap. Something that I've been thinking about within this, as we continue to have expectations of our increasing access into talking therapies, is what impact could have, will have, maybe have our new primary care workers in mental health under the R scheme. And if we're signposting more people into the 3rd sector for things, maybe some of the more social determinants of mental health elements like housing, benefits, access to leisure and hobby activities, employment, do we risk, or is it the right thing that access within IAPS diminishes a little bit because of finding people more appropriate services than that? Not something I think's been thought about too much nationally, but something that's entered my mind, really. We're putting in these lots of alternative ways of doing things. What impact will that have on our Talking Therapies team? Trusted assessments. If anyone's been around as long as I have, we've been talking about trusting each other's assessments for at least 25 years, and that's just my time in the NHS in mental health. But how do we genuinely move to a position where the people that access our services don't have to repeat their story endlessly? Again, it's a significant thing that our users say is distressing and re-traumatizing, is to keep repeating the information to us. And I guess we have to acknowledge that different services will need different information, but there's core information that we should trust each other's judgment on. And I suppose the other bit for me is that fluid pathways. What I often see is that the step up into secondary care is entirely appropriate. I don't always necessarily see people being stepped back down once their mental health is stabilised, particularly around severe anxiety and depression, when in fact we're stepping up for a stabilisation type approach. And as people recover, having them access our Talking Therapies team, I see people ending up and maybe getting stuck in secondary mental health care, when in fact there might be better ways of doing that. So yeah, just some thoughts, really, considerations about that guidance, but certainly if you haven't had a look, urge you to have a look at that. And that, bang on 1:40, is the end of our presentation. So hopefully we've got some questions, and I can see we have. I'll stop sharing.
Hello, thank you. That was really interesting. Sorry, I threw myself off because I greeted you like a ghost, and then that kind of that threw me right off. But
have I stopped sharing, Vanessa?
You have. That was really insightful and really helpful, and what a great springboard for the beginning of hopefully many more informative talks about community mental health. I've got a second screen here. So we've got quite a few questions that have come on, and I'm going to read them in order that they came in to be most fair, starting with Lucy, who asks, is the psychological intervention facilitator role similar to the clinical associate in psychology role, but for people who aren't eligible for some reason, of who can't commit to full-time training, etc., or a step before this?
It's basically there as a role, maybe as a step before there. So it's really around bringing people into therapy careers who wouldn't necessarily currently meet the thresholds for some of the more structured training courses. And often it's about people who are very strong academically but not been given the opportunity to have the placement post qualification. So, but I also think it's important that we also think about some people not necessarily having the opportunity to develop into those careers from a more lived experience perspective, but are very, very representative of our current communities. So I think there's a mixture of people, really, but I would see it as a step before CAPS.
Yeah, me too. And I think there's something around being a stepping stone into training, if that's what people want to do. And I don't know if this would resonate with other people. I think it's been more difficult for people to enter some of the PWP type training, mental health wellbeing practitioners, the children and young people's wellbeing practitioners. At the undergraduate level, it's kind of like quite often geared up for the postgraduate kind of level. So I think this gives people that opportunity, as Steve said, to be able to demonstrate, to interview a range of skills that they've developed to step into those roles. But certainly we see it very much as a kind of developing a career pathway for our non-registered staff, and making sure that the opportunities beyond that are endless, really. Why not up to the more senior grades?
And I would just sort of add that we've had a number of people from the cohorts go on already. So a quarter of the people that have entered the PIF training have moved on to do the mental health and wellbeing practitioner training because they feel that more confident in that arena to be able to engage in structured training, and also can back up the clinical experience. But likewise, we've also started to see people applying for the PWP training as well. So across the entire division, it's actually been helpful for recruitment and retention of those core roles.
That's interesting. An exciting prospect. So the next question is kind of similar ilk, and actually, Rachel, I've bundled your 2 points together. So Rachel asks or states that they're level 5 and they're looking to do a master's in psychology, but they're having difficulty finding funding from the NHS. And then she goes on to ask about short-term therapy. She asks, do you think that 6 sessions really help? She's heard of a lot of complaints from that style.
Do you want me to take this one, though?
Go for it, Steve. I may chip in, as I always do.
So it's around the dose, I guess, is the most important thing. So within the talking therapies arena, I'm a massive advocate of step care. I think it's really, really important if it's delivered appropriately. 6 to 8 sessions can be used very, very effectively with people to the point of recovery. Now, the secondary care provision that mental health and wellbeing practitioners and the PIFs are delivering are based on a 12-session model. So it's specifically adapted for time-limited intervention. So you're delivering things at a slower pace, which is more reflective of the client group that you're working with. And it's not, it's important that you actually focus on the needs of the individual. We know the science is there. We've got lots of years of experience of the science in terms of what interventions delivered in what sequence work. The important thing is we don't lose sight of the artistry, which is actually making it relevant to the patient and helping the patient to move forward. And what we've seen by the implementation of these roles in community teams is that there's been a shift in terms of how they're used. So as part of a wider care plan, rather than just seeing that practitioner, they've maybe got 4 or 5 people involved, but actually that really targeted piece of work is instrumental in helping them move forward with other aspects of their care and support plan.
And just on the, I guess what I would say around 6 sessions is that if that question is related to step 2 and the interventions delivered by PWPs in our talking therapies teams, the evidence actually suggests that going beyond 6 sessions doesn't bring about any increased benefit. But what you should be looking to do if people haven't made the required recovery is stepping up to a higher intensity therapy. If you're talking about 6 sessions being delivered as a routine at step 3, then that's an inadequate dose and you're very unlikely to see the benefit of that. So yeah, I guess in terms of how the question was being asked at step 2, absolutely appropriate. For other therapies, probably inappropriate.
Thank you. So Lucy has asked, she's interested to know which CCBT program you have chosen for this population.
We currently in our talking therapy services use Silver Cloud, so it's a specific program that's been developed for secondary care called Space for Recovery, and there's also some of the adjunct ones that we use. So Space for Money Worries. We do allow the access to the wider suite of CCBT programs, but to make it more reflective of the individual's presenting needs, Space for Recovery is always the one that we promote in secondary care teams.
Thank you. This next question, I love. What were your top 3 challenges for implementation and how did you overcome or mitigate against these?
I'll give you one while you think, Steve, of the other 2. Just to share the load. So I think one of the most significant challenges, probably with both roles that we've introduced, is getting the understanding and buy-in from the existing clinicians in the teams, who perhaps felt that we were trying to replace them or weren't quite sure how this would fit into the model. We very much took advantage of the mental health wellbeing practitioner training really early. And I guess a little bit opportunistically. So a lesson learned, we could have done a little more with our teams to prepare them. Although we've employed such a good bunch, they've well and truly integrated themselves into the team and let the kind of existing clinicians know what they're there to do. Our next piece of work really is to ensure that all the different roles are quite clear in what they're delivering and etc. And I'm probably moving into one of the other questions about counselling. Absolutely, I see that as part of our workforce going forward too. Being able to provide that range of interventions in secondary care that we've got within Talking Therapies. But that'll be my first one, Steve, which would be around the integration and the staff being prepared for such new roles.
I think sequencing is a major challenge within which bit you do first, and I think that links very much into the other aspects of it, which is as we've talked about quite exclusively, is about developing that workforce, and particularly the trained workforce. And I think one of the massive benefits to what we've done is where we've got those deficits in terms of those trained practitioner posts. We know over the space of the next 3 to 5 years that we will be in a position to recruit to those posts from some of the work that we're doing. So although it's a slower way of getting there, we are actually chipping away at that wider problem as we go. But the sequencing aspect, I think, is really, really important, because what we've needed to do is introduce some of these new roles to enable us to free up the time to get some of the existing practitioners space to engage in their CPD and their own development. And as Nick's saying, that the relational models is something that really does interest us, and we would love to see a lot of our trained staff engage in some of the wider therapy models, so DBT, IPT, DIT, alongside bringing in some of the counselling aspects as well.
Well, then I've got a third one, Steve.
Go on, go for
it. So I think it probably something around, and this is why the transformation is trying to challenge the whole care program approach program, without saying that the principles of CPA are not important and relevant. They are. It's that care coordination within CPA has become an intervention. What are you doing with this person I'm care coordinating? When, it's very important that someone coordinates care, but really what we were looking for is the best person in the right time to provide the intervention that the person needs. So with the new roles coming in, some of the traditional staff within the team still feel they need to hold all the cases in terms of risk and complexity. And I guess that's something that will develop as they develop more trust in these new roles that have been developed, when in fact it's the supervisory arrangements and the skills and support that they get that's more important than somebody holding all the cases. So I kind of visit teams and see the CPNs still with 60 on their caseloads, and everybody else seemingly having a really nice time with much lower caseload. So we've just got to shift that balance, that it is the right person at the right time providing intervention, and that care coordination as an intervention disappears. As a function, very important, but it's not an intervention.
There's another question that follows on really nicely. I'm sorry if it's going to sound a little repetitive, but anonymous attendee, right? How is the front door managing referrals into the service? We do not struggle with the recruitment of non-qualified roles, but greatly struggle with the recruitment of core qualified staff to support people with the most complex of needs. What are your challenges of the implementation of transformation in your area?
Great question. I guess at the moment we've got a variety of methods in which there are indeed the front door. So moving away from a front door to multiple doors, no closed doors. But again, that's not easy. We still have a single point of access where GPs can send their referrals through to. So that's still in existence. But what we're wanting to move to is those locality models that I talked about, that each locality has a defined workforce, if you like, and that referrals, again, I'd like to change the language of referrals, are discussions within localities, with MDT-based discussions in terms of who's best placed to meet people's needs. So, still transitioning from traditional models of having a single point of access, but also moving towards that conversational element. And I think the mental health, your kind of primary care mental health practitioners under the R's roles are a really key part of this. So doing those initial triages directly in primary care, and hopefully given their access to mental health services and the fact they are employed by us yet deployed to primary care, they've got kind of open access and should know our services and know what's going to be appropriate to meet people's needs.
I think there's potentially as well some massive gains that we could make digitally. I mean, we've seen, within our Talking Therapies service, the implementation of digital onboarding via the websites. We use Limbic for that. But I think there's some really exciting development work, maybe to look at secondary care pathways of, which are a lot more complex than the Talking Therapies world. What potentially digital offers as a route in for people, and also to support people in the navigation from the front end of services right the way through to their discharge.
And I think the second part of that question in regards to not struggling to recruit non-qualified roles, absolutely, same here. But ensuring they've got the right skills to be able to practice in a different way is why we created the PIF role. And I very much see the mental health and wellbeing practitioner role as a qualified role. That is a university course for a year at postgraduate level that is intended to meet the needs of our service users within secondary mental health care. So that's an additional role that I think that we've put in so that we can maintain and use the expertise as our core qualified staff rather than trying to do everything. They do the bit that they're really good at.
Lexa Turner, actually, just as a note, in the answered section, someone has left a comment about training at Teesside, if anyone would like to have a look at that. So Lexa Turner mentioned how primary mental health services outside the NHS can find benchmarking more difficult, but also referring to NHS secondary care. How do you think this could be improved in the shorter term, recognising this is an area that NHS England has been looking into for many years, as well as the BABCP?
Yeah, I suppose I also said that that's not been too much of a challenge for us because I manage all of them services, but I absolutely get that. And I would be really urging the kind of, the providers to be getting together to do that benchmarking together. Hopefully you've got good relationships. If not, I think that it's fundamental to any success around the transformation that you do. So that would be my kind of my thought around that. Get talking.
There's Lexa actually follows on with how I'm intrigued, perhaps controversial, but would it be more cost effective to offer qualified PWPs, the psychosis and bipolar training and the secondary care training rather than creating new roles such as PIFs? Mindful this could be a way of enabling more informed, appropriate referrals and stepping up, down more efficient, essentially a bridge between primary and secondary care services by existing clinical workforces.
We had a very interesting question. I guess if the national team were here, they would certainly be frowning upon any thought to be using PWPs for something other than in talking therapies, because that's what they're trained to do. But take the point that you could train people to do other things. The mental health wellbeing practitioner is intended to learn the lessons from PWPs. It does things that PWPs don't, in terms of some training around. Actually, I'm going to lie. I was going to say training around medication, but I think medication is covered in PWP training. But it is intended to be like a PWP role for secondary mental health care. So the training itself incorporates that. I see the PIF role as less of a replacement for a PWP type role and more of an upskilling and enhancing of a support worker role. So yeah, I see that kind of bit below, and then being able to access PWP, mental health wellbeing practitioner training, etc. beyond that.
Wonderful. Steve, do you have anything you'd like to add?
I was just going to say is that I think the actual more important thing, as we talked about perhaps more in terms of step 3, is the movement of the pathways more closer together. So I think actually getting your PWPs and your mental health and wellbeing practitioners in the same space to close some of those gaps would actually be more effective for me.
So we've only got a few minutes left, so we can call this the hot fire round, so to speak. Someone's asked, have you adopted the Dialogue Plus care planning tool?
We were an early implementer who was well on our way to developing our own outcome measures, and then NHS England recommended the use of 3. That language has changed somewhat in recent times to being recommended. So we are using a tool very similar to Dialogue Plus, but we like the language and we like the recovery focused element of it, and it's called the IROC. And we will be implementing the other 2 outcome measures that are recommended nationally, the goal-based outcome measure and the REQUAL, Recovery and Quality of Life Scale. So we will be embedding those, but we'll be using the IROC rather than Dialogue Plus.
The benefit to that is that it comes along with a complete toolkit for the clinicians to use in their care and support planning, called the HOPE toolkit. So clinicians really like it, and all the patients that we've used it with really like it too.
So 2 last questions. First one asks, what about retention and development programs for AHPs and OTs and social workers? We've had a few gaps in our trust of staff not feeling valued and then leaving. And then the next one talks about the single front door, but let's answer that one first.
I think the first question in terms of that retention piece is really important. It's a really important thing to acknowledge. Again, don't have all the answers, and we have some similar challenges. But from my experience, and I'm not an OT or a social worker, when we ask people who are trained very specifically in certain things and certain evidence-based interventions, and then ask them to become generic workers, I think that's when people can feel a bit undervalued and de-skilled. There are elements of the registered professional roles in which, of course, there are commonalities, but I would say an important part is to make sure people can deliver the skills that they learn on their relevant training courses. Everyone brings that kind of different approach. If you limit that, I think that's when you'll see people wanting to go into roles where they can use their training.
I think there's been some really simplistic things that maybe could be helpful within that. So, for example, our newly qualified social workers, OTs, is we ensure that they have OT and social work on their name badges, so that their professional identity is retained from the word go. Because, you know, often now people go out and recruit for mental health practitioner roles that, you know, any of those qualifieds can apply for. But, you know, if you spent 3 years of your life training for something, you want to sort of get the reward for that. So I think that's really important. But just going back to the thing that I said earlier about sequencing, I think the sequencing is really important as well, because the CPD elements and the elements of people feeling they're developing within their roles are actually a key part of this for moving it all forward. And that's for all professions: nursing, social work, OTs.
Wonderful, thank you. And then the last question, so I know that we're now overrunning, but someone's asked that they want to know a little bit more about the single front door. How do you plan to balance the triage referrals between TTAD and CMH? Is there a plan to create one point of contact or input a self-referral in your area?
Yeah, I think, not to preempt something, but I think it's such an interesting topic that could easily make up another one of these sessions in itself, to think about how that works. But ultimately, yes, I guess what we've had in for many years now is the self-referral option into our Talking Therapies teams, who can then end up almost triaging on behalf of mental health services, because that's an easier way of accessing services. So those staff spend their time going, that's not appropriate, that should be somewhere else. So I think there's something about the trusted assessment model. We are looking into assessment hubs in localities, and there's something about that working in localities and the conversational piece about how you get appropriate referrals into the right place, with the primary care mental health staff playing a really important part in that. But yeah, I'd love to say I've got the answers nailed down, because it's a work in progress. But yeah, it would be a really helpful ongoing discussion and see what other people are doing too.
Wonderful. Any final comments, Steve, before I sign off?
No, nothing from me.
Wonderful. All right, well, thank you. I hope I've tried my best to cover the questions. Sinead has actually written that she's got to go now, but she says it's been wonderful, really insightful, but she's got an initial first assessment with the service user to go do. So this is real NHS Talking Therapies in live time.